Hello and welcome to The Conversation from the BBC World Service, the show that amplifies women's voices, which is really just a fancy way of saying that we bring two incredible women from different parts of the world who share an expertise together and see what happens. Today's programme comes in response to an email from a listener. Maureen Johnson, who is a registered nurse, works part-time in the Canadian Arctic. She says our closest hospital and closest doctor is over 500 kilometres away by air. There are no roads and only two nurses in the small Inuit community. Maureen wanted to hear from others delivering healthcare in remote places. So I'm joined by Dr. Lungile Hobe, Medical Director at Mseleni Hospital in South Africa, situated in a remote northern part of KwaZulu-Natal near the border with Mozambique. And Dr. Melanie Matthews is in Australia and works at a health clinic in Maningrida, a small town in Aboriginal land at the very tip of the Northern Territory. Lungile and Melanie, welcome to you both.
Thank you so much for having us on the show.
So firstly, I'd love to hear a little bit about the places you both work in. Lungile, how big is Mseleni and where is your nearest city?
So Mseleni is a very small town. It's not really a town, it's a rural reserve. That's what we call it in South Africa. So a small tribal authority. We still have traditional councils governing over the land. We provide for a population of about 120,000 people in total, but that's spanning out probably about 150 kilometers to the south and about 50 kilometers to the north, another 60 kilometers midlands, and then all the way to the coast. We are within Ismangaliso Wetland Park, and like you correctly said, about 60 kilometers from the Mozambican border. The literacy in the area is below 60%, and unemployment is also very high in the area. So obviously poverty is also rampant.
And Melanie, how about Maningrida?
So Maningrida is a Aboriginal community in West Arnhem Land in the Northern Territory. So it's on Aboriginal land, the Kumbudji people, and it has around 3,500 to 4,500 people, depending on the time of the year. Our closest hospital is a 6-hour drive away or a 1-hour flight, which is in Darwin. The community exists of lots of different clan groups, and English is usually the third or fourth language, with around 8 to 10 different languages in the area. And we also service outstations or homelands for the local First Nations people of around, there are about 25 of them, and they're either 20 minutes away or 3 or 4 hours away on dirt roads.
And Lungile, how many people is your hospital actually responsible for?
It's the 120,000 people, but we run a 185 bedded hospital, and then we provide for 11 primary healthcare facilities, but we also have community health workers, around 190 of them, and then we are able to then reach the whole spectrum of the community with all those people and services.
How far do they have to travel to get to you?
So initially, when I said the furthest south we have to provide is around 150 kilometers. If you're driving a hospital vehicle to get to that clinic, it's about 1.5 hours to 2 hours. But a public transport commuter will maybe be hitchhiking or getting a taxi, getting dropped off somewhere else. It might take them somewhere between 3 to 5 hours. But we do, as a hospital, work closely with emergency medical services. So we provide a bus service that goes to that primary healthcare facility to fetch those patients. But then it means they only come to us in the evening. And by the evening, most services have closed down. So X-ray is not available overnight except for emergencies. So then they have to sleep over and only get service the following morning. And then some of these patients have to be further transferred to other facilities.
If, for example, your hospital can't cater, because I'm assuming it's not a very big hospital.
So things like your advanced ortho surgery, we don't do here. So those patients will have to be further referred to a hospital that's about 200 kilometers away. So for that patient to get there, they will have to come here, sleep overnight, take a midnight bus, travel there, get seen the following day, and then hop on the same bus back and probably arrive here on the midnight of the following day. And obviously they can't be traveling at midnight because of lack of transport and lack of security. So they will sleep over in the hospital, travel back home on the third day.
That's sounding like a lot of travel for people who are going to be quite ill. I mean, that's a lot to consider. You have a smaller population, obviously, but they're equally spread out. Is this also a consideration for you, that these people are ill? How do they make it to us when they're in these conditions?
Yeah, the logistics can be very difficult, as Lungiel has already touched upon. So particularly if people are sick at an outstation, can we get out there? Because for 6 months of the year, we are cut off because of the wet season, because everything floods. A lot of people will come into the community because of that, but sometimes they don't. And so can we get out there? Up until recently, we only had one ambulance in the community, and we are the ambulance service. So if we're sending an ambulance out to that outstation, we then don't have the ambulance in the community for any other emergencies. If we do bring the person in and they don't need to be evacuated, where do they stay? Do they have family? Because we don't have accommodation available and we're not a hospital, so we can't admit people. And then for really sick people, so yes, we have a similar thing with an evacuation service, which is a charity called CareFlight, who will send planes out to retrieve really sick patients and take them into Darwin. But even that can be really tricky. And as you can understand, when you live in a remote community, that's where your land is, that's where your family is. You don't speak English as a first language, you're then being taken to a city hospital, which is big, sterile, scary, confusing, and often they're not allowed to have escorts because the government won't pay for them to have an escort go with them, so they're going by themselves. I try and advocate as much as I can for people to have a family member go with them, but often it's not my decision and that doesn't happen. You know, it's a really big deal, and it's hard. So yeah, logistics is a really big issue for people, and when you're sick, it's, you know, it makes it extra difficult for everyone.
How big is the actual health clinic, and what can you manage there and what can't you manage there?
Quite big compared to other communities in the Northern Territory. So we have a 2-bed emergency, and then the rest of the, I guess, clinic is based around primary healthcare and, I guess, programs. So chronic disease, child health, rheumatic heart disease, mental health. And we have probably around 20 nurses who work throughout the clinic in those various areas. And then we try and have 2 to 3 doctors on the ground. Sometimes I'm there by myself, but we also have some telehealth backup as well. And we just have to manage anything that walks in the door. You have emergencies going on, but then you're also trying to manage primary health care, which is so important for the community, because nothing is ever going to improve for the community if that isn't addressed. And I guess one thing that I do want to mention is that we are an Aboriginal community controlled organisation. So we're not government. It's about self-determination. Our board is Aboriginal people in the community, so they can have a say about their health and about their healthcare and what we provide, which is really, I think, so important in the setting that I work in, because as Lungiel said before, with her community, where I work has very low socioeconomic, conditions, very poor people, low education. As I said, speak English as a 4th or 5th language, poor literacy, low education rates, and very, very poor health compared to the rest of Australia, which, you know, is sort of put up on a pedestal as one of the countries that has an amazing health system. And yet we have groups of people who have much lower life expectancies and really poor health outcomes, and diseases that don't exist in the rest of the country, like rheumatic heart disease.
Lungil, when you hear this, obviously there must be quite a lot of similarities.
I feel like we are a bit better off than what she's describing. At least I have a hospital where I can admit these patients. I can stabilize them. In my hospital, we even have a 4-bedded high care unit where we are able to ventilate. So as much as we are very remote, I feel that we are a little bit more equipped than what Melanie is describing. But we've also formed a network of doctors in South Africa called Rural Doctors of South Africa. And within that organization, we're able to network. So if I'm short of anything, I'm able to shout out to the next person and say, hey, don't you have this? Or how do I do this? Or how do I cope in the situation? So yeah, I feel a little bit encouraged, and I feel bad for Melanie that sometimes she has to be stuck with these patients and being unable to assist further.
I mean, it's a lot of responsibility, both of you. You're working kind of at the extremes in some ways. Does it weigh on you at all, Melanie? Just how difficult the situation is?
Yes, it absolutely weighs on me, and it has for many years. I think my greatest anxiety is the doctor shortage, which is throughout Australia, particularly rural Australia, and remote even more so, which is just getting worse, not getting better, which exists throughout the world, really. And my biggest anxiety is being left there by myself, because this is the work I want to do. I love it. I don't want to do anything else. But rural and remote work is not what people want to do anymore. And so, I work really hard in trying to create a network of doctors that come up regularly. But it is really tough, and it does weigh. I feel like sometimes at the end of the day or the week, you're just exhausted with the responsibility. And, being the sort of the senior doctor there, where every person in the place is coming to you and you're responsible for so much, it's a lot. And so I think, as Lungil was saying, networking is really important, and being able to contact people in similar conditions is really important. And that's something that I do.
Is it difficult to recruit people, medical professionals, to work in more remote places?
It's very difficult. But again, in South Africa, we've been fortunate that over the past few years, the South African government formed a relationship with the Cuban government. So they were selecting mostly rural students to go study medicine. And over the past few years, those students have been coming back in numbers. So for instance, in my hospital, they're coming in here and they're staying because, this is home for them, but also they have bursary obligations as well. So I must say, over the past 3 years or so, it's been much, much better. I remember in 2019 when I think we were down to 5. And yeah, so that was tough. And the only people we could recruit were from Congo, being refugees in South Africa, because South Africans were just not interested in coming out so remotely.
And Melanie, you've actually studied this issue, the issue of recruitment.
Yes. So last year, 2023-24, I did my Masters of Public Health at the London School of Hygiene and Tropical Medicine, and I did my dissertation. It was a literature review on the attraction and retention of primary care physicians in rural and remote areas worldwide, and sort of looked at all the different factors that affect why people go remote and why people stay. There's no one thing that fixes things. It's a wide variety, and it varies greatly depending on gender, so whether you're male, whether you're female. In Australia, we have a very high international medical graduate population who have to go and work in rural and remote areas, but then the factors about where they pick and where they stay are also different for them. So it's a very complex issue. And we certainly do not have the answer in Australia as yet.
Lungil, you're in an interesting situation because you come from the area that you work in. How do you balance the fact that you work and you live and you're in the same place and you're a lifeline for so many people? I'm assuming everyone you bump into pretty much knows that they can come to you for advice. And I assume that at times that means that you can't switch off in the way that you might want to.
Yeah. I basically grew up here. So everyone knows me. My peers are now my age. So they're having families and having issues. Some have fertility issues. So, and there's still some taboo issues within the community that you can't just rock up to a hospital and say, hey, I have this. So you need like a friend that you can chat to privately. So I get all of those things. And then you even get people coming to my house and saying, hey, I noticed that one of our neighbors is sick. Do you want to come and see them? So, I mean, it's quite interesting though. I think for me, I just love people. And I think that's basically what has kept me here. So if I can assist, then yes, I will gladly assist. But it does take a toll on you. But I think for me, being here in this community is also an advantage because my mom and dad are still alive and they are within this community. My mom-in-law is also still alive. So I never struggle with the kids. I also have such a cushioning. I have such safety netting in my personal life that I feel as much as I work very hard, I'm still very well taken care of. I come home and I don't have to cook or I don't do my laundry or something like that. So I think those things, they may seem minor, but they keep you going.
I'd love to know what got you both into this, actually. Lungil, how did you decide to become a medic and a medic in a remote place and not move to the city?
I don't think I've decided to stay remote. So I don't want to say like I'm going to invest the rest of my life in remote medicine. So the hospital I work in, my mom used to work here as a nurse. So I think one of the earlier stories that inspired me was my mom got into a very bad car accident when she was at work in 1993. She had a very bad skull fracture. Had there not been a doctor working here, I'm convinced she was going to die. And we continue to see such stories even in my current work day, where, once we had a child, I think they may have been 7 years old, they were knocked down by a car, came in, we could see the brain, they had a very bad skull fracture. But we managed to stabilize her, sent her away, and she came back walking. And then just walking through the corridor one day, she comes over to me and she says, I love you. And I'm like, oh, you still recognize me after all of that, So it's about human connections as well. You meet people, you get them better, and they still come back and say thank you, which I don't think happens quite often in urban medicine.
Melanie, you actually grew up in Melbourne, which seems like quite literally a million miles away.
Well, it is. It's a very long way.
I mean, you said that you knew you wanted to work with Indigenous communities, but tell us your origin story. Tell us how this came to be. And I understand that you actually wanted to start off as a surgeon.
When I was 17, my parents and my sister made the move up to the Northern Territory to a place called Katherine, which is a sort of large town 3 hours south of Darwin. I'd never been to the Northern Territory before. And my dad was actually working in an Aboriginal health service in Katherine. And I had the opportunity to go out into some of the communities. And I guess that was my first taste of Aboriginal remote medicine. And then I was lucky enough to get some extra placements throughout my university degree up in the Northern Territory, and I absolutely loved them. I then sort of went into the hospital system as a junior doctor, where you don't do any primary health care. And, surgery is, pretty sexy and exciting. Decided I wanted to do that. And then a couple of years later realised, actually, I love the surgery. I hate the lifestyle. So I really don't want to do this. But then a friend said to me, well, remember those placements you did back in medical school that you really enjoyed? And so I thought, well, let's give that a crack. And I was lucky enough to get a 3-month placement up in Maningrida, actually, back in 2014. I loved it. I applied for GP training. I got in. I never wanted to be a GP, but the breadth of the medicine that I was enjoying in remote communities, being a rural generalist, was what attracted me. And I guess that's what's kept me here. I moved from Melbourne with no view of going back. I actually can't stand it when I go to big cities anymore. Wow. I find it really difficult. And it's kept me here. I just love it. For one, I think the privilege of being able to work on Aboriginal land with First Nations communities. The Australian First Nations people have some of the oldest cultures in the world, and some of that is dating back 30, 40,000 years, and that still exists. And so I guess being part of that community and being welcomed into families is just so special. And then being able to provide healthcare for really some of the most disempowered and poor people in the country. It's most people in Australia have no idea what these remote communities are like. If they came up here, they wouldn't even they would be like, are we still in Australia? Because it's so completely different. And we're providing self-determination, and the communities are able to have a say in what we do. We work some of the most important people we work with are our community workers who grew up, live in the community, and they bring patients in. They're our translators. They help me traverse the cultural divide and, the different belief systems. And they're some of the most important people, and working in a team environment as well with them, with the nurses, with allied health. I just love that. And I really want to try and improve the conditions and the health outcomes in Maningrida.
I mean, I can see in the way that you're both talking that you carry the weight of responsibility. I will say, I think the work that you do is clearly absolutely incredible. And being that you're both so experienced, I wonder if you would have advice for young people or people who had just started going into remote places as medical professionals.
My advice would be every human being deserves the best healthcare. And I think one of the things I often share with my team is that I believe in God, and I believe that there's a God in each and every one of us. So I often encourage juniors to look at patients with sympathy, but also think that you can be in the same situation one day. And treating other people with compassion means that it has to start with you. You can never, ever be compassionate with the next person if you haven't learned to be compassionate with yourself. So mental health is number one. You have to look after yourself so that you are able to look after others well. If you are not coping, you need to realize that you are not coping and then get the help that you're supposed to get. Sometimes it just means taking a few days off. And I often encourage my junior staff that on weekends, if you want to switch off your phone, you're not really working, then switch off your phone or switch off the work messages so that you are not involved in anything that's happening in the hospital. But just make sure that when you come to work, your full focus is on your patients.
How about you, Melanie?
I completely agree. I think looking after yourself is so important. Being remote is hard and the job can be very difficult. However, it can also be so enjoyable and fulfilling. And so making sure that you're looking after yourself, that you're taking the breaks that you need is really important. I think be willing to be part of a team. No one in the team is more important than anyone else. A big issue that we have is people coming in and thinking they're going to fix everything. The problems that have existed in Aboriginal First Nations communities have existed since colonisation, and a lot of horrible things have happened since then. You're not going to come in and fix it. You need to come in with open eyes and take in what is happening around you. And yes, some ideas are helpful, but don't come in and think that you know the answers. Working with the community is what's the most important thing. We're not about coming in and telling people what they should be doing and what they shouldn't be doing. It's about what does the community want? What does the community need?
Can I just say thank you so much for all the incredible work that you do. It has been very, very interesting, actually, speaking to both of you. My guests today have been Dr. Lungile Hobe from South Africa and Dr. Melanie Matthews from Australia. Thanks for listening to The Conversation on the BBC World Service. If you want to hear more episodes, do like and subscribe to our YouTube channel.